want to try and do in the next sort of 15 minutes is share with you some thoughts and some concerns and potentially some opportunities around if and how the conversations globally around the global compacts are or aren't influencing what's happening at a regional level and what's happening locally. My work is around migration and health. So I do a lot of work using health as a lens to explore other issues around migration policy, but in particular looking at health from a public health approach, population health as a key imperative, health for all. And so there are real questions around, does migration offer an opportunity for us to strengthen those responses? And I would argue yes. But then the danger comes if certain concerns around around migration then start to overwhelm progressive conversations around health. Really, oh no, not that one, that one. So we have seen over the last couple of years a renewed focus globally on migration and health. And what we've seen is a couple of processes which have included the IOM and the World Health Organization around talking about the global relevance of responding to migration within the context of health. Like the Global Compacts, this is an attempt to link back to the Sustainable Development Goals. It's around trying to readdress a pre-existing global compact on universal health coverage, on thinking about broader issues of justice and the right to health, and importantly, helping us to start thinking more constructively about why some of our health responses are failing. And many of us would argue that's because we're not considering the movement of people. This isn't about the movement of people across borders specifically, it's about the movement of people more generally. In our region, as I mentioned earlier, we know that the majority of people moving are moving within the country, yet our health system responses don't facilitate movement. If I move from one province to another, if I move within a city, continued access to healthcare can be very problematic, with implications for broader public health issues. If we're looking at trying to work out how to respond and improve our responses, we're faced with a range of competing agendas, some of which we've already heard about, but the issue around politics, the issues around power, in terms of who and how policy discussions are being led, and importantly, concerns that are being raised within the public health community around the impact of the securitization of migration and the impact that would have not just on people who move, but on broader public health. This is often driven by this idea of the fear of the other, the fear of the person who moves being framed as a diseased person, a person who's bringing poor health and having implications. And whilst our colleague from IOM this morning is correct that migrants move with their health status, it's not that that health status is automatically bad. The majority of the time people who move are actually healthier than the communities they leave and the communities they arrive to. But that's not the rhetoric. It's not what we're hearing at local, regional or global levels. In 2008, a resolution was passed by the World Health Assembly for the first time on the health of migrants. And this was calling on member states to start thinking about how to improve responses to migration. It was driven mostly by a Southern European agenda, but it was quite productive. It was limited in relevance for our context, and that then led to the next phase, which has been a global consultation last year, which was, as I said, convened by IOM along with the World Health Organization and the government of Sri Lanka, to explore where we are now. Where are we 10 years later and what needs to change? This discussion and debate and the meeting was framed around the global compacts. And it was an opportunity for many of us to raise concerns about if and where health and well-being are or aren't included in the global compact processes, both for migration and for refugees. And what is really clear is that our concerns have manifested. So whilst last year, as a subsequent follow-on from this global consultation, a new World Health Assembly resolution was passed, which is calling for the fact in 2019 we should be able to present a draft framework for the health of migrants and refugees globally. And this is important, and it's important not only because many of us might believe in the right to health, it's important for bigger issues around global health security, etc. But it's being completely omitted from the global compact discussions around migration and migration management. The zero draft did include, I think it was 2 mentions of the word health. which was more than many of us expected. The revised draft has 0, which is what we anticipated. The draft of the Compact on Refugees again mentions health, but it's a very political issue, and it's as political as migration in many ways, and the minute you try and put the two together, you're dealing with an even more complicated kind of mess of the issues that need to be addressed. So I had already put in this discussion around the Common African Position, and it was interesting, like I say, to hear that in some spaces it's now been heard of as being approved, and in other spaces we're not sure, and all of this kind of complication. And the reason I'd mentioned this was about trying to start thinking about global to continental, and then on to what this means regionally. And what we saw in this process, as has been mentioned, it was quite closed door, but it also had some very productive opportunities. A series of consultants were appointed across across different regions of the continent to provide background input papers. And I'm more familiar with the Southern African space. There was some consultation. It was limited because of the limited time, etc., etc. So it wasn't what we would all be wanting, particularly not in terms of civil society engagement. However, there were attempts to push agendas around health, well-being, and issues beyond border management into the conversation. And I think that the conversations that then happened in Addis were quite constructive. The challenge is what then happens at a continental level, particularly when we're thinking about health, and we're thinking about the fact that health and well-being mean different things in different countries. And we haven't got a common African position on health. So how can we have a common African position around migration, which also includes health? Maybe we're asking too much. So one of the key things that is of great concern when we're looking at the global compact process and we're looking at what it means regionally is this idea around securitization. We might want to use different language, we might want to talk about it being around protection of those who move. I would argue it's totally contrary to that. It's about border securitization, it's about nation states. And we need to be asking questions around the security for whom. It's not security for those who move, it's security of those who are members of particular nation states. We need to think about security for which values, and I would argue that they're not rights-based. I would argue that the values that are driving this are around fear of the other. And this is having implications on more productive conversations around the ways that states function. How much security, security from what threats, and security by what means. And this is where, in the public health world, there's a history, and it becomes dangerous. There's a concern within the world of public health that we might be seeing a return to the use of health as another layer in global security, and using health as another border, as it were. Bringing in health checks on borders, for example, going back to the days of Ellis Island in New York, where you were screened when you came off the boat. If you had a limp, you were put back on the boat and sent back to Europe. There are concerns that some of the gains made, for example, around the right for people living with HIV to move across borders. There's a concern, are we going to see a return to that? The conversations around securitization at the global level have provided an opportunity for the misreading of public health. And it is a dangerous time. And I think many of us are very concerned around this global health security agenda being co-opted and misread and misunderstood to potentially support some of the global compact processes. I was recently at a global health security symposium, and some of the language that was coming out around stopping people crossing borders and the change and shift in that language compared to if we'd had that meeting 3 years ago was very telling. So we've got these competing security agendas, we've got things we've talked about this morning around essentially sovereignty and the ways in which nation states feel that they would have the right to close their borders. And then we have this idea of free movement, which we know in the African continent and within the Southern African Development Community has not been a progressive, constructive conversation. We know we're not going to move towards, in Southern Africa, a free movement protocol. We know that's not on the agenda, as it were, for South Africa, which as a result means it's off the agenda for SADC. We then have these additional security agendas which are being pulled and pushed and used in different ways that are drawing on kind of health framing and health issues and public health. And like I say, I'm concerned that we're seeing the constructive conversations around health for all that we've been working for many years to put back on the agenda, where issues around migration were providing an important and positive leverage for re-engaging in these conversations. And we're starting to see a converse on that. So what does it mean for those of us who have been calling for thinking about migration and health in a constructive way, and suddenly our language, our work and our research is being turned around to suggest what we're saying is actually that migration is bad for health? So in Southern Africa, I mean, I don't have much time, but there's just 4 key things that I wanted to remind us about. We all know this, but you know, the mixed migration flows is critical. The majority of people moving are moving within countries or within the region. This isn't a big exodus of movement from elsewhere on the continent or from Southern Africa elsewhere. There is that movement, we need to think about it, but the majority of issues around mobility and migration, particularly in South Africa, are internal migration. The global compacts do not consider internal migration, and they are further stigmatizing the idea of migration only meaning foreigners and only meaning people crossing borders. This is very dangerous, particularly in the context of health. We know that our current public health responses don't engage with migration and mobility. And here, as I said earlier, I want to emphasize, I'm talking about movement generally. It's not about the right to healthcare for refugees, the right to healthcare for those who move borders. That's an important and critical aspect of a bigger conversation around migration and movement. In a region that has such a long history of the movement of people, with such an established history of ongoing communicable disease burdens, it always amazes me that our health systems haven't gotten around to planning the need for regional movement, for intra-country movement, particularly around continuity of treatment. And what I'm worried about is that some of these conversations, as I said, are being co-opted. This is why we should then stop movement, because we're saying it's difficult for people moving between South Africa and Mozambique to continue HIV treatment. So the way to resolve that is we stop people moving. And there's a real danger that the challenging conversations where we've made little progress at a regional level are going to be further, what would the word be, further stalled and turned into this dangerous rhetoric. We know that there are a range of health issues that we haven't done as much as we should be doing. And the main reason I would argue is much of that is because it involves the movement of people and the fact that we haven't developed responses that can deal with treatment, prevention, testing, whether we're talking about malaria, whether we're talking about HIV, and increasingly non-communicable diseases. We know that our public health and social welfare systems are struggling, and we need to be very careful when we're talking about migration to reiterate what I've been banging on about, that we need to be talking about movement and migration in relation to nationals as well as to non-nationals. We need to ensure that people do not think we're starting a conversation to exceptionalize the non-national as being more in need or more worthy of services. We need to rather talk about this collectively. And again, this conversation is starting to be co-opted into an argument for why we should be closing our borders. Because our health systems are struggling, if we keep out the non-nationals, who only make up 3% of the South African population, suddenly we're going to resolve our public health crisis. We know that's not the case, but it's a convenient argument that has been given strength by the global compact process. And finally, we know that the broader issues of structural violence, which is what we see informing many of our policy processes. The politics of policy making trump the idea of evidence informing policy. This is a fact that we know. It's not just around migration or health, but we still are stuck at a point where we don't know how to overcome that. What should we be doing with all of these discussions to rather think about where our evidence goes? I think there's many of us in the room who know of, have generated a part of processes that generate what I would argue is good quality evidence. But we're not able to ensure that that evidence is informing processes. And for me, that's as much of a crisis as it is whether we're focusing on the global compacts. So just to end, I want to argue what I think is needed. And I'm coming at it from a health perspective, so you know I'm biased. But we need a public health approach. And a public health approach, I argue, is something that everybody engaged in migration policy should be thinking about. And the reason a public health approach is important, I'm biased, I'm a public health person, is because it allows us to be all-encompassing. It forces us to think about structural issues around the rhetorics that are driving policy, but importantly it forces us to look at a broader population. It forces us to recognise everybody and not only those who in this case might be those who move. So it's forcing us to think about policy making for the greater good of everybody rather than some kind of moral panic. How we resolve that again, I don't know, but I think it's an important entry point. We need a renewed regional conversation. By that, I don't mean relying or asking colleagues in SADC to run a SADC consultation. We need to rethink our bilaterals, we need to rethink how different member states engage or don't. We need to rethink how the Department of Labour continues to manage, mismanage, whatever words we want to use, the importation of migrant labour with the mines. We need to rethink regionally what it means to engage with the private sector, particularly in the South African context. And these are our leverage points for rethinking conversations around the Global Compact and around migration management. Because who's going to be suffering? Getting the private sector on board, even though I hate to admit it, I think is critical. The private sector are influenced far more around the impacts of the Global Compacts and so forth and migration management than essentially the rest of the state. And we need to think about that and what and can we and how can we leverage. And finally, we need to scale up good practice examples. And again, this is another example where I think issues around evidence aren't used. There have been some excellent interventions, very low scale, that have involved partnerships between civil society and the state, that have been driven by healthcare workers on the front lines, that have been driven by productive and constructive district health people to pilot small interventions. Things very simple like patient-held records, working to ensure that individuals, when they move within a country or across a border, know where to go. These very small initiatives, because they're contrary to sort of the popular policy and public and political space, don't get the traction they need. And I think we need to be using some of those to think beyond the health space and think more carefully, cautiously, and constructively around the opportunities that do currently exist.